Dream machine. DICOM, HL7, I-18 in the snap. We're building the future, never looking back.
What do jet engines, air traffic control, and radiology departments all have in common? Well, more than you might think. Today on Imaging Informatics Unplugged, we're diving into the world of digital twins. Not clones, not science fiction, but real-time, data-driven models that are helping reshape how imaging departments operate. Our guest today is Robert MacDougall. He's the co-founder and chief commercial officer at Quantively, and they've set out to unlock better imaging for more patients by building the air traffic control of radiology operations using data and machine intelligence. Now, before co-founding Quantively, Robert led medical affairs at Canon Medical Systems USA and served as director of the diagnostic and nuclear medical physics programs at Boston Children's Hospital and Harvard Medical School. He's board certified in diagnostic and nuclear medical physics by the American Board of Radiology. And to top it all off, he's a certified imaging informatics professional. In this episode, we explore why many imaging departments still don't fully understand how their operations actually run, how structuring HL7 and DICOM data into a unified semantic layer can unlock massive value, and how AI recommendations are being used to improve access, revenue, and patient satisfaction. So if you care about radiology workflow, data strategy, or just want a glimpse into what the future of imaging operations might look like, hit subscribe and let's jump into it. Thank you very much, Robert, for joining us today on Imaging Informatics Unplugged. And we'll dive right into our conversation, which I'm looking forward to today. And let's start out by talking about the term digital twin. So this has been a term that has come up a lot over the past few years, and it often has a lot of misunderstandings. I was curious if you could share with us when you're engaging with different imaging departments, what are the kind of the misunderstandings that you're seeing when it comes to this term digital twin, and how does that blind spot skew the way leaders evaluate these types of projects?
Yeah, let's do it. So I think the concept, I was even just reading online a paper about digital twins for clinical trials and cancer research, right? So that's a perfectly fine and amazing use of the approach, which is to model, model a real patient sort of in silico, create a virtual model so you can test things like, treatment, long-term effects in a kind of virtual model, as opposed to running these large-scale clinical trials with real people. So that's fine. And the concept even goes back really far to really modeling any complex system in software, right? So you think about making jet engines. You don't just make 1,000 jet engines and experiment on them. You try to understand from a modeling perspective what impacts the performance before you kind of go into production. So I think the concept is broad, which is a good thing. There's many good uses of it. In our context, in radiology operations, which is the problem that I'm focused on, is we think of the radiology department and even the hospital in a broader sense as being this very complex system, right? So you have resources, things like MRI, CT scanners, you have staff, radiologists, technologists, you have anesthesia, you even have child life specialists. You have all these workflows, you have billing, and there's so many interdependencies, and it's all connected, like how you schedule patients. And it's a very complex system. And today we kind of refer to this problem as being really, there's like an operational black hole, which is no one really knows how the system works on the ground. And so we thought there was an opportunity. There's just so much data that's produced in a hospital, but radiology is probably even the biggest data producer, to structure that data in a way that it's useful to then create models with the data that model your operations in silico. And then you can do things when you have a model of your operations then you can start asking questions like, what is the biggest lever I could pull to, for example, increase patient access, or increase revenue, or reduce delays, really anything that you can think of. And then you can ask the model, what's the biggest lever I could pull to achieve that goal. And then it can create essentially all these, simulations of different scenarios and serve you the highest impact intervention. And even if you don't have an end goal in mind, you can ask, if you're in radiology today, there's a lot of Lean Six Sigma work, continuous improvement, quality improvement that goes on, which is amazing. But it's kind of done in this, observe, measure, this very manual approach. And before you start any of that, you might want to know if it's even projected to have an impact, what you're thinking of, so you can't model all these things, manually. So if you have this digital twin, you can actually ask it, what if I changed my protocol for, I don't know, picking anything, an MR brain with and without contrast from an hour and 15 minutes to 50 minutes? Would that allow me to scan more patients in a day, or would that reduce repeats or have some impact on quality? And it's a much more efficient way of doing this quality improvement and continuous improvement for reaching the goals of the department.
Interesting. Yeah, it's funny what you mentioned data user. I may be a little off on these stats, but I think I'm within the right ballpark where I heard a stat that said 30% of the world's data is represented by healthcare. And then of that data within healthcare, about 80% of that is imaging. And so it really, right now, radiology is the predominant imaging digitized format. There's other specialties that have come around, but we're talking significant data. I find it interesting when we in healthcare we lean on the expertise of other domains. So you mentioned, within like building a jet engine, you're not going to build out 1,000 of these and then hope that they work. You're going to want to make sure that there's a model to prove. Is that where the motivation of the organization that you're with kind of came from? Was it from kind of another outside industry, or did you bump against this as a challenge that you were seeing within a local organization and wanted to do this? I'd like to hear where the conception came from.
Full transparency. So the way that it worked, I mean, the company was founded at Boston Children's Hospital, and it was really the kind of origin story was that a lot of people had different questions of operations, not even talking about the simulation and digital twin, but just literally providing some visibility into the data and performance, like what's actually happening on scanners in the department. And even that was a basic question that people were unable to answer with the tools. So what we first created was what we call this unified data layer, and maybe we'll get into this, but it's just a way of structuring all the data. So you think about, HL7, things like SIU, ORM, ORU messages. Then you have the DICOM world of the pixel data and the metadata. And you might even have other databases, right? So you have like staffing databases, you have protocol databases. And you want all this data to be structured in a way that it can all be used together. If you were to ask a basic question, like how many of my exams start on time, just that sounds really basic, but you need the scheduling HL7 message of like when the appointment was supposed to start, and then you need all the machine produced data on when it actually did start and end. So it just started on creating that data layer structured with an ontology that was made sense for radiology operations. And then my co-founder, actually Benoit Scherer, he it's funny, he did his PhD. He won like the gold medal PhD award in France for agentic AI in 2009, which is crazy because a little ahead of his time, right? I always make fun of him that, is there a difference between being early and wrong? But he did, he was an expert in this like 16 years before it's kind of the buzzy word now. But we had all that expertise in the company baked in, and then we realized we have this data layer. Obviously, we should create these models on top of the data layer. And that's what we were doing. And we didn't have a name for it. We were just modeling the data. And then it was very difficult to explain that in so many words. And really the concept of the digital twin that existed for so long was the exact kind of framework and concept that we were doing. We didn't call it that in the beginning, but we realized at the end that that's exactly what we actually were doing. And people understood the concept. So it was easy to communicate what we were doing. Having said that, the downside is, so people understand the concept, but usually it is true that it takes 30 seconds to clarify that we're talking about the department level system, not a human body or something like that. But I think that's okay. I think people, when you do clarify, they immediately then understand it pretty well.
So the unified data component, I want to expand a bit more on this. So
Yeah.
HIMSS has defined the 4 levels of interoperability. There's foundational, where we've got 2 points that are going to be able to send data between each other. Then we have structural interoperability, where now we're looking at, we have structured standards like DICOM and HL7, and now I can send that data, and 2 different systems can the receiving system can understand what the sending system was sending, at least from a structural perspective. It can read it. And then we get into that 3rd layer, which is semantic, and being able to really truly understand, and this is where ontologies come into place, because we have HL7 that has components of data that somewhat relate to what we may be looking for in the DICOM side of things. And in many cases, whether it's body part description or whatnot, or procedure description, they could be vastly different across different areas, or how they're labeled within the EMR versus the PAC system. And how does, what are your thoughts around tackling this as far as an ontology to harmonize this type of disparate information when we're looking at semantic interoperability?
Well, it's exactly the right framing, the semantic level that you're talking about. The DICOM itself is, an ontology and HL7. And so for better or worse, when you define something, you both add clarity and kind of remove some of the nuance, or you actually lose some information as well. The way we think about it is we start with these ontologies like HL7, DICOM, maintain that information, but then we add our kind of, ontology, the semantic layer on top of it all, which is critical for the model. So I'm trying to think of an example, and people say words and a lot of meaning gets lost. So let's just think about an exam, like exam duration, right? What does that mean? So today, if you ask that, people say, yes, we have exam duration. And it could mean any number of things. So it could mean, for example, let's just pick the largest kind of RIS, EMR, Epic, Cerner, whatever you want. There's a click where, a technologist can say, I'm starting an exam, and a click that says, okay, I'm ending an exam. And at the first level, okay, that represents the exam duration. But what if you say, I'm starting an exam, go get a patient from a waiting room, do a metal screening, they go in, you take them out of the room, you do all the 3D recons, send them to the AI algorithm, or whatever. There's no patient in the room, and then you hit end. Well, it's one concept of an exam duration. It's maybe not reflective of the room utilization, for example, or the scanner utilization. And so you have to add a new concept, which we do, which is literally performed exam duration and room utilization. And you can also have scheduled exam duration and schedule utilization. The schedule utilization is how much of the schedule was blocked. The room utilization is how much time is the patient actually in the room being imaged. These are concepts that don't come from the existing ontologies like DICOM and HL7. So semantic layers. So we don't see, what we're trying to do is not to, there's a lot of the second level you said, the structural. It's important those structural concepts are maintained for all the interoperability that exists now. We don't want to gut those and replace them, but there are applications, operations, scheduling, utilization, financial. There are applications that require a semantic level on top of that. And really that's what we do. And then you can start adding, there's so many concepts that come out of that. One, just to give another example, then I can turn it back to you. But if you think about, we have what's called a start delay, which is when a scanner is staffed at the beginning of the day. So technologist, scanner's operational to the first exam. That's like a start delay. And actually, you'd be amazed that there's usually, there could be like an hour gap or something. And maybe for good reason, no judgment here, but that's a concept that it sounds so basic and is very important. Or an end delay, like there's no more patients for the rest of the day, but the scanner is kind of live and open. Or there's a service, there's a maintenance time block, right? That's a concept that's important if you want to audit the downtime of a scanner. That's not something that's in like a DICOM or HL7, ontology, but it's critical to operation. So it's exactly the semantic layer that we're tackling specifically with respect to operations.
Interesting. So you're attacking this, and it sounds like throughout this process, there's new concepts and new definitions that are being modeled just because of, as we start going down the path of looking at implementing new operating solutions or whatever, we're going to need to define new terms to make sure that we're all on the same page as far as what specific things mean. And again, I think your point is a really strong one, where we don't want to gut anything out. We don't want to change how it is existing within the originating data set, but it's a matter of trying to make comprehensive, meaningful understanding out of what is being conveyed there.
Yes.
So I'm curious, during the process of implementing a digital twin, where you have the opportunity of, you mentioned identifying, I guess, gaps would be a first area where, and then, if we make this change, then we can start to see a reduction in the turnaround time on reporting or whatever metrics that we're looking at. I imagine there's probably a list of default go-to scenarios that most people are looking for in this. And then I'd be curious, first off, to hear what those are. And then I'd be curious to hear what are the unexpected ones that come out of this. Are there opportunities where, as a result of running through this, now I can see that something I never even thought of before, there's now an opportunity within my reach that I could be attaining because of these insights?
Yeah, it's funny because we start with being in the weeds and we think there's all this cool stuff you can do, and there is. And the most like when we first implement, it's really the basics of the basics that people want. They haven't ever been able to answer. Literally, what is my room utilization or scheduling efficiency? Those two things compare the synthesis of the HL7 and the DICOM and even some quality measures. They just haven't had access to that. Or even looking into the future, what's my third next available appointment? What's my schedule utilization 2-3 weeks out? It's just this, what we call this visibility. So we do what's called like a health check. It's kind of like if you get an Apple Watch, right, for the first time and you throw it on, you might look at your heart rate or sleep or whatever. And it's just like, how am I doing relative to? And then are there any big red flags of things that I should address? And so we kind of run this health check and say, you're really, even before we do anything else, typically the North Star, honestly, is access, it's revenue, and it's patient satisfaction. And those three are common almost universally. So access, imaging more patients, or decreasing wait time, and really also to avoid leakage of basically patients to other neighboring providers. Revenue, obviously, for obvious reasons, and patient satisfaction, reducing delays, and also reducing wait time. So with respect to those kind of North Stars, we run a health check and tell you, what's just needs to be fixed sort of now. And through that iterative approach, there's a lot of value that people get out of it. But the funny thing is that asking a question and answering a question always leads to more questions. And it's kind of where just traditional business intelligence or analytics falls apart, if you have like this really, sorry to go on the tangent, but if you have this really kind of rigid dashboard system or something, it's it can answer one question, but you have a follow-up question and it can't answer that. So we started from the approach of really trying to be very bottom up. When I said like building this data layer, that means making it flexible to really try to answer any question that you might have in the future. So yeah, those three North Stars are very common. But then one interesting one just off the top of my head is a measure of quality. So you know, so we do an automated, for example, ACR compliance check. If you're a provider, you get accredited by the American College of Radiology in the US typically. And it's funny how you do it. Every 3 years, you send in these phantom images and some of these patient exams. And you say, here's how we do it. And they say, oh, great. And then every 3 years, you check back in and submit a new one. Well, can you do that more in real time? And every exam that's coming in like that, for example, an MRCP, which is a type of exam, can you just check that all the series are actually acquired, sent to PACS, how many repeats, and to try to avoid also these calls from radiologists to the scanner, say, hey, you missed a series, or can you kind of, you missed coverage. So it's really about doing this quality check on exams. And then there's other things like financial modeling, and we can talk all about it. So more answers just lead to more questions, but the first ones are really this access, revenue, and patient satisfaction.
You initially gave the analogy of wearing a smartwatch, and so it will collect data for you, and it gives me a bunch of can act on if I choose to.
Yeah.
And so often I find when solutions like this come around, there's an opportunity where I've collected a lot of really useful information, and unless there is a real clear guidance on what I'm going to do as far as next steps, the information will just sit there, and now we know maybe how bad we are. But where does it fit in to the implementation of something like this to make sure that there's actionable steps taken forward for that site after they've collected and identified some of this information?
Yeah, so that's a really good point. So the first is the health check, telling you what's wrong, but it can't just be that, which is what's bad or what's not performing. You need to provide very concrete actions that someone can literally take and do something with. So we have this concept of an intervention that is suggested. So I don't know, maybe I'm stretching the analogy, but if you got a I don't know, you're something with your health, and one of the interventions could be try walking 10,000 steps a day. You're walking 1,000 steps a day. Try walking 1,000 and let's measure you. So we have attached to these areas of improvement, we have what's called these interventions, and you can literally like add them to a cart. Like I want to add the intervention for reducing the start delay. I want the slot utilization good. I want to change the appointment duration. You add them to the cart, and then a single person is accountable for kind of executing that intervention. And then you can, once you start the intervention, you just track that intervention over time, and you don't just forget that you did it. It's logged, and then statistically you can try to see if that specific thing is having an impact on the North Star that was originally identified. So there's a couple things. It's attaching to these like insights, or I'm just using the generic term, not what we call them, but about what might not be performing as well as you'd like. You have to attach these, what we call like atomic interventions, which aren't these just big broad things, but there's something that somebody can actually do today, and then track that impact over time, kill the things that aren't working, double down on things that do work, and and implement it like that. Hope that answered the question.
It definitely did. So we see the benefit, and there's a lot of tangible, real practical benefits that implementing something like this can provide insights. We can act on them, and then really, if I'm the one at a CIO level, like I'm going to see an opportunity where it's going to impact the bottom line. There's an opportunity where there's some revenue opportunities for improvement. So when you're having conversations with organizations, what do you tend to hear as far as like the skeptics go, that may be resistant to something like this?
Yeah, it's funny, healthcare just there's so many potentially mixed, not incentives, but like goals of people in hospitals. Um, and that can be, it makes sense. And it can actually be a good thing. So the benefit that we have is we don't see there being really a trade-off, right? So if you think about increasing access, increasing revenue, and increasing patient satisfaction, there's not really a friction between any of those. If you increase access and image more patients, downstream of that is revenue. It's really more about identifying, the specific incentive that a specific person has. So whether it's an operational leader might be interested in revenue, and this more clinical leader might be interested in access and patient satisfaction. So it's trying to be clear about the ROI in each of those separately. But in the end, I think they all serve the same higher level goal. I mean, the skeptic, so to answer your question directly, even me, like if I were to put myself in a hospital, I would be skeptical because I've used analytics tools or business intelligence tools in the past, right? And they just don't ever live up to what you think they're going to do. They look cool and they can have these nice flashy dashboards. But when I see a dashboard right now, like I actually get terrified because I see this like heavy thing that is very, very brittle in a sense of doing more with it or answering these follow-on questions that I alluded to earlier. And that would be and I would be skeptical, and that's when people really are skeptical. The way we quickly try to clarify is that we've really taken this bottom-up approach of doing the data layer and then making the data layer flexible, where now we even have a natural language interface to just ask questions of the data. Like, tell me my most delayed exams, or what can I do next week? And it's literally like a chat GPT on your data, right? That's trained on our ontology. That's very different from a dashboard world or like alerts or these interventions. But the old world of dashboards was almost starting with, and even dashboards, we just hate that word. I tried to say visualization, so visualizing the data, but people, it's going to be hard to kill that word. But if you think about a dashboard in the old world, you start with that thing that you want to see, and then you almost like shoehorn the data into it, right? Like, what data do I need to collect and clean? And sort of do this like ETL in the data science world to like make the dashboard work. And then that's fine, but it's just so brittle that if you want to ask another question, well, the data is really kind of forced into this fixed dashboard, and it's not really can't really answer another question unless you want to create another really heavy dashboard that'll take 6 months or something like that. So I think that's starting with the application or the dashboard first is really dangerous. I think it's the trap that a lot of business intelligence and analytics tools sort of fall into. Whereas if you start from the bottom, then you can do things really quickly on top of it.
And you had mentioned that your co-founder had written an article, hard to believe, in 2009, so before AlexNet, on agentic AI. So I'm curious, as we start seeing opportunities for recommendation engines and the opportunity to identify that here is a gap if you make these changes, and some of these changes may not require physical human interaction. So there's an opportunity where we could start automating some of these changes. What are your thoughts about handing that over to automation to allow that recommendation engine to start making some of those changes? I'm curious about that, and I'm also curious, like, what do you think the governance checkpoints and just the how that will be received from the clients as far as handing that automation over, and depending on what the, I guess, recommendation engine is suggesting?
Yeah, you'll have to come by at RSNA where I can show you this more fully, but I will. It's exactly our vision, right? So our vision is to really build what we call this, like the air traffic control for radiology departments. And these agents, agents do things for a goal. So we see this as being incremental. So right now we have exactly what you said. I mean, an intervention is essentially generated by like a smart recommendation engine, right? It's like this thing that you should do. It is a recommendation engine. And that's a human doing something. So that's what we call like, that's a human doing something. It's still a manual thing for the human to, for example, implement a schedule change in Epic or something. We see that moving from just a human to like a human in the loop, which is an agent really just creating and executing an action with approval. So they go more from like the implementer to the approver. And then this is a way to just build up trust over time. And then in the end, you can go from what we call a human in the loop to human on the loop, which is like the orchestrator, right? And then you're really like the conductor of the orchestra as these things are going and then you have guardrails to make sure things are going according to your plan. But it's sort of, you think about airlines and the way that you have to book with a travel agent, and then you, book yourself online. And now there's dynamic pricing for booking a ticket. I get on a United Airlines flight to New York. Somehow I know to within 5 minutes when the plane is going to land. And I also know where my luggage is and if it was left or if it came with me. I can pre-schedule like, an Uber or whatever. So you kind of see the same flow, right? It's like we're still honestly in the kind of going between the travel agent and booking a ticket online. But in the end, this thing has to work in a much more efficient way with humans being the orchestrators. And yeah, so I don't have the full story. I'd be foolish to tell you that I did, but that's where we're going incrementally, learning along the way how to do it properly. Yeah.
Terrific. So I try to keep these conversations to around the 30-minute mark. It looks like we've just hit about 30 minutes. So maybe what we'll do is I'll give you an opportunity just to close out with any last points or thoughts that you wanted to share with the audience.
No, I mean, I think what we're building is, I'd love to hear from anyone who maybe has a similar or different perspective. So feel free to reach out on LinkedIn, or you can go to our website and talk to me. I think that it has to change. I mean, in radiology, we just see this tidal wave of demand coming, right? So people that are in radiology, we think about this latent demand for diagnostic imaging and wait times, especially here in Canada. I'm born and raised in Canada. The wait times are crazy right now in Canada, and something has to change. Then you have this new surge of even like theranostics, drug discovery, biomarkers, right? Like, how are we going to image all these patients? And the economics long term don't make sense. So providers are going to have to find a way to image more patients to be competitive. We've seen all these mergers and acquisitions in the space. I think that just comes from the overhead administrative cost of healthcare. I mean, healthcare is 18% of GDP in the US, which is just wild. Something has to change, and this is our sort of swing of the bat to make some big changes in radiology. But would love to hear from people that are looking around these corners as well.
I'll make sure to include your LinkedIn URL in the show link, and also a link to your website as well for your company. But yeah, thank you very much. Really appreciate this conversation. I think we'll definitely be chatting about this a bit at SIM, and I'm sure we'll hear the word agentic a lot when we're at SIM as well. So
indeed.
Thank you very much, Robert.
See you in Portland.
DICOM 807 IHE in the snap. We're building the future, never looking back.